All right, everybody, we're at the top of the hour, so I'm going to go ahead and just get us started. My name is Michael Martin. I'm with Comagine Health. I am part of the Hospital Improvement Innovation Network, the HIIN, out here in Nevada. Comagine region, we have Oregon, we have Utah, Wyoming, Idaho, and Nevada. We'd like to welcome you here for the Reducing Readmissions Town Hall with our special guest, the Northern Light Mercy Hospital System in Portland, Maine. Just a few tips on using Zoom. We are going to put everybody on mute except for the speakers. We will unmute the lines at the end. If you would like to ask questions at the end, we do ask that we let our presentation continue forth, and we will have plenty of time at the end to ask any and all questions. Feel free to also use the chat. If you look down here, there's a little bubble that says chat. You can go ahead and use that now if you already haven't. Please chat in your name, your organization, where you're from. That just kind of gives us a better record of who's attending. And you can also ask your questions in there. So if during the presentation something pops up and you want to just jot it down, go ahead and throw it back in that chat box. And at the end, we'll go back through and we'll pull those questions and read those questions as well. Let's go to the next page. If you're calling in on this, star 6 is to unmute. So once again, at the very end of the presentation, if you'd like to call in and ask a question, just press star 6 and that'll unmute your line. Unfortunately, if you're calling in, you won't have the ability to chat, so I do apologize for that. So we're going to go ahead and get started. Just a brief overview of what we expect to kind of hear some of the stories from the hospital about. With that, I'm going to go ahead and pass it over to Lisa Kasher. She's going to introduce herself and just kind of jump right into it. So Lisa, if you can unmute yourself and go ahead and take over.
Well, thank you. Welcome and good afternoon, everyone. Thanks for inviting me to speak today regarding Northern Light Mercy's Readmission Reduction Program. I'd like to share some of the programs, what we've instituted, how we sustain it, and where we're going. I'm Lisa Kasher. I've been at Mercy for 26 years. And in the different roles that are described there, I did take I stayed per diem. We took a short hiatus to go to Portsmouth Regional Hospital in New Hampshire and worked on an open heart unit there for a little while. And I'm currently back in school pursuing my master's in nursing education. Next slide, please. So a little bit about Mercy, there we go, thank you, sorry. So Mercy is a not-for-profit 130-bed small community hospital. We just recently celebrated our 100th anniversary. We do have a Catholic affiliation, and we do still have Sisters of Mercy on our board and on our staff. Next slide, please. We have 2 campuses. This is one of our campuses. We are hoping to consolidate within the next 3 years. This is our State Street campus, and it includes several different kinds of services, some of which are duplicative of our other campus. Next slide. And this is our Fore River campus. So this is our newer campus, and this is where we'll be moving to. It's on the site of Fore River, which is on the ocean. It's a beautiful site, and includes the services listed there, specifically our non-complicated orthopedic, urologic, gynecologic surgeries, as well as our maternity center. Next slide, please. So this slide demonstrates how from Q1 of 2016 to Q4 of 2018, how Mercy looks compared to the state and New England. And our blue dotted line there, or blue thick line there is us at the bottom. So we're well under New England and we're well under the state. And if you consider that nationally, which I don't include on this slide, this is a product of our health-centric group that is our quality improvement organization. But nationally, readmissions as given by CMS are typically between 17 and 18%. So again, we're still pretty well underneath that line. Next slide, please. So readmissions have been a hot button topic since about 2010 when Medicare realized that they were spending $17 billion on preventive, potentially avoidable readmissions. And as most of you know, in 2013, CMS levied penalties for heart failure, AMI, and pneumonia readmissions. And then in 2015, they also included COPD, hip and knee replacements, elective. And then in 2017, they also included coronary artery bypass graft, CABG, and expanded to different types of pneumonia as well. We do not perform CABGs here at Mercy, so that diagnosis fortunately did not affect us. That is a high readmission group, so I'm glad about that. So Mercy was subjected to CMS penalties for the years of 2013, 14, and 15. And fortunately, the penalties were decreasing. We have not, however, had a penalty since 2016. In 2012, our highest readmission rate was CHF. And in 2012, Mercy received a grant from Harvard Pilgrim to create and implement a heart failure patient navigator program that would that included inpatient intensive education, one-to-one, minimum of 60 minutes, started from admission to discharge, and also looked at our practice and to ensure that we had evidence-based practice and that we also had post-hospitalization follow-up. And we also connected with our home care and our telehealth, and we provided staff education. And we were fortunate in that we then got a second grant when that one was completed, the first one, from the American College of Cardiology, so that we could continue the program. And then we realized how successful it was and just turned it into a position here in the hospital. So fortunately, we had a lot of support from administration to be able to do that. So we're so successful in seeing that our readmission rates were being reduced that as a multidisciplinary team decided to apply several of the practices that we were using for the heart failure program to all of our diagnoses. So this is really what's led to our current readmission program and the strategies that we're currently employing. Next, not yet, oops, sorry. Thank you. So this slide includes the practices and the programs that we've got in place, and I'm going to go into further detail on several of them and as we go along. The one intervention that I don't have a slide for is palliative care, and the one at the bottom. So we are very fortunate here at Mercy. We have a wonderful, compassionate palliative care nurse practitioner who sees patients by consult, and she primarily sees chronic illness patients, but she sees patients that are frequent flyers to the ER, or they're just seemingly spending a lot of time here in the hospital with readmissions and really trying to eke out goals of care and what they're really looking for, and also assisting with advanced directives. Next slide, please. So without the participation and buy-in from these key players, we would certainly not have the success that we have had. All the team members share the same community approach with input from a variety of actors across the continuum of care, and resulting in better healthcare outcomes within the hospital and at home. Next slide, please. So Integrated Care Management and Resource Center. So this is our group that it's fairly new. It's been within the past couple of years that this has been implemented. So this is actually often referred to as the hub from our end. So this group came about from when we joined Northern Light. When Mercy was freestanding, we did not have this. So this is a product of that. So this is a group of social workers, nurses, and MAs that will call patients. They're at a central core for care management of the hospital. So a lot of them even work from home. And they do a lot of the behind the scenes work for referrals for home care, nursing home requests. They do PASARs. They schedule post-discharge follow-up appointments. They do post-discharge phone calls. We still have care managers within our facilities. There are sort of boots on the ground folks who are there meeting with patients, identifying barriers, needs, home support, financial barriers, transportation barriers, health literacy, mental health needs. They're at the bedside, the care managers. So our facility still has an amazing group of care managers that are working directly with our patients. But this Integrated Care Management Resource Center kind of alleviates some of the time-consuming pieces that care management was taking up, so that this kind of freed them up to be able to spend a little bit more time with patients. Okay, next slide, please. Transitions Home program is one of our programs that we have. It is a nurse practitioner that we, actually she has her own practice, and then 2 days a week she dedicates to seeing patients that have been discharged from Mercy. And so we refer from the hospital, we get permission from the patients, and she'll be within the home, we're in the home within 72 hours of discharge. She calls the patient, she schedules an appointment, and she shows up. She'll perform med rec, she does full assessment, she'll contact primary cares as needed, she reviews all the discharge instructions, she makes sure that the patients are able to get their meds. So we do use this as an adjunct to a PCP. We'll particularly use it for folks that have new and complicated diagnoses. We'll use her for folks that it's a real hardship to get to a primary care appointment to follow up. And we have a tool that determines how high a readmission risk someone is. So we'll use her and make a referral to our nurse practitioner for those folks that are high risk, readmission risk patients, and or patients that we see who are really struggling with the discharge plan and are coming back. Next slide, please. This is a new program to Mercy as well, Meds to Bed program. So this just started about a year ago. And we're working out some kinks with it, but we have a pharmacy that's embedded in our medical office building. And so they're notified of discharges, and they will call the patients at the bedside and ask if they'd like to have their medication delivered to them. And then they'll bring the meds right to the patient in their hospital room. It works very, very well for one-time prescriptions. It works well for patients who have a hard time with transportation, who maybe can't get out to the pharmacy easily or don't have delivery. And there are a couple of kinks with it, one of which is that the patient has to be able to pay their copay right there at the time. So if they don't have a credit card or they don't have cash, or they don't have family members that might be coming to pick them up who could help with the payment, that's sort of one of the glitches we're still working on. But it does work very, very well, and it really has helped with, particularly with antibiotics, with, like I said, the one-time prescriptions, antibiotics, steroids, those kind of things that, it's a limited time, and so the patient actually will leave with that in their hand, just about guaranteeing they'll be able to take the med when they're supposed to be taking it. So, and particularly if they have an evening one. If the patients are discharged after hours, after their pharmacy closes, it's particularly handy as well. They also will help our care managers with costs, because they can run the prescription with the patient's insurance, so that we can find out the cost of some of the newer, more expensive meds as well. Next slide, please. Northern Light Home Care and Telehealth is our affiliated home care group, and they are Northern Light Home Health and Hospice. They provide home care for patients who are homebound, for Medicare folks, and for folks who have commercial insurance. They don't need to have the homebound restriction. They do have access to our EHR, which makes a smoother pathway to the continuum of care. The telehealth program has been really, really helpful, and this was one of the first things when we started our patient navigator program. One of the first things we really wanted to dive into deeply and get much more use of, because when we first started this program in 2012 with the patient navigators with the heart failure, We really didn't have much knowledge of telehealth, and most of the nurses didn't even know it existed. So we really collaborated with the Northern Light Home Care folks to find out about telehealth, the best uses for it, and we now have, at any given time, we can have up to 270 patients on telehealth. And what telehealth entails is a scale with a blood pressure cuff with an oximeter that the patient will have. It's installed in their home. They're not charged at all for it. The patient does have to be under services of Northern Light, though. And it turns itself on at whatever time the patient designates and asks the patient to weigh themselves, to then sit down, check their blood pressure, check their heart rate, check their oxygen level, and then that information will then go off to a nurse who's monitoring for alerts. There's also an education piece attached to it as well. So if there are any alerts that come up, then the nurse who is at Northern Light will then call the patient to check in, see if we need to send a nurse out, see if we need to make a doctor's appointment, see if we need to call an ambulance. We do have diuretic protocols. We also have COPD protocols. So we use this primarily for our COPD and heart failure patients, but we also expanded it to some other more complicated diagnoses that we really just want an extra set of eyes on. So we'll have signed by the PCP protocols in place so that if the patient's having a flare of COPD, we've got a kit in the home. We just have them start the antibiotic and the steroids. We have IV diuretics in the home. First, we start with increasing the oral, and then if that fails, we can go right to the IV. So this has just been huge in keeping our folks out of the hospital. And Northern Light, or the home care team, keeps track of how many times they've actually activated their protocols and sort of call that a save as far as keeping somebody out. So it's just been tremendous. And the collaboration with these group of nurses, they get back to us, they email and tell us what's going on with patients that we've discharged, so that if they need somebody to reach out from the hospital, we can do that. And it's just, the communication has just been tremendous, and probably one of the biggest pieces to our success, in my opinion. Next slide, please. So the Patient Navigator program, like I said, provides one-to-one intensive, extensive inpatient education to the patient. Starts from the day the patient's admitted right up to the day the patient's discharged. We also do follow-up from home, make sure that the patient's hooked up with cardiology, pulmonology, the home care, the nurse practitioner with the Transitions Home program, and this we're doing for heart failure, COPD, pneumonia, and AMI. I didn't include pneumonia in there, but I'm also doing it with the pneumonia folks. And the patients, I hate to say they behave better, but when they know you're going to call, they tend to be a little bit more engaged in what's going on with their care. So when we discharge them, we say, well, we're going to call and check in just a couple days, and they expect the call, and we usually will fill out a checkoff list that says what's been going on, and see if we need to call the doctor or make sure that we can ask the questions. Did you pick up your meds? How are you taking them? Reviewing discharge instructions and that kind of thing. But the piece here that's so great is that because it's a dedicated person who can do this inpatient education, it takes the stress off the nursing staff to just try to get incidental teaching, which is pretty much what happens in the hospital, that you can actually sit down at a quiet time with patient and family and really provide this kind of education. So we also have a specialized booklet that we designed that we use with the patients. We have a daily weight calendar that we also provide. We made up a magnet that has all the information with an emergency number on it as needed to call. And we've got some dietary instructions for patients as well. So that's really the Patient Navigator program, and that's pretty much, that's been very successful as well with our heart failure patients in particular, but that's kind of where it started, so that's where the strength lies. Next slide, please. The patient-centered medical home. So we have 6 primary care, Mercy primary cares, and they're very whole person centered. The care is coordinated across all the elements of healthcare, including our home care, our specialty care, our end-of-life care. Mercy Primary Care Centers also have social workers so that they can help with mental health care. And we also have embedded transitional care coordinators within each practice who will get discharge information. They'll get notified when there's a discharge, and then they follow up with the patients as well to make sure that, again, the patient's got appointments, that they've got, they're able to get their medication, that they understand their discharge instructions, they have access to the EHR, so we're all in the same place and they can look up that information. Next slide, please. The discharge risk screening is something that happens in the hospital. So there are 2 screenings that we do, one of which is to determine how much need a patient requires for care management. If they're pretty independent, they're a 35-year-old who came in with some chest pain and just needed a rule out and they came in from work, then obviously they're pretty independent. They're going to probably not need much. Care management will touch base, make sure they're okay, and then they'll have a lower score, as opposed to somebody who's got 35 comorbidities and they have maybe a homeless situation or food insecurity or that kind of thing. So that's the first screening tool we use. And then the second screening tool is what we call the LACE tool, which a lot of facilities are using. And we do that at time of discharge, and it determines how quickly the patient needs to be seen after discharge. And then we make the appointments prior to the patient actually being discharged from the hospital based on that score. Next slide, please. So these follow-up appointments, these are the ones that were really determined by the LACE score as well as almost by gut. If you know that you've got a patient that's going to be a little more challenging or have some real struggles, then we'll obviously be scheduling appointments a little bit sooner. We'll also use our transitional health nurse to, if it's particularly a complicated diagnosis or very new to the patient, we'll have her follow up as well. We make appointments within 7 days of discharge. Really, it's 5 business days. If their score is moderate on the LACE, and if it's high, then it's within 48 hours of discharge. If it's over a weekend, it's a Friday to a Tuesday, or kind of to a Monday. But it's within the 48 hours of the discharge, really, to it. And then we do a discharge audit on a monthly basis to ensure that this is being sustained throughout the hospital and that the units are all doing this in an appropriate fashion. And now we've got the Integrated Care Resource Center doing it as well. So it's taken a little bit of the time out from some of the unit coordinators that were doing it or the nursing staff that were making the appointments. Next slide, please. So we also now, this is also one of our newer positions. We have a Readmission Specialist, and this is through our quality department. This person looks through all readmissions, everybody who comes back in within 30 days. If they're orthopedic patients, it's within 90 days. And looking for causes, interviewing patients, try to figure out if we didn't find a barrier that should have been identified, if there are any in-house providers that are in a pattern showing some gaps in care, and then addressing that with the providers, as well as making sure that the discharge instructions really did include all of that which the patient needed. So we're looking at gaps, we're looking at improvement opportunities to see what kind of communication needs to happen that maybe didn't, and making sure that we're adhering to evidence-based practice as well. So we review all the discharge instructions and also perform the audits for the follow-up appointments. We also met recently, well, actually, we can go to the next slide. So our outcomes thus far with what we've worked on, we've had a decreased readmission rate, like I said, over the past 5 years. We have had no readmission penalties. Our patient satisfaction scores are significantly higher than they used to be. Our HCAHPS, we use Press Ganey, and we've been getting more and more back lately, as well as getting better scores. So things are really looking up from that end, and Mercy's overall length of stay although we took a little bit of an uptick when the Integrated Resource Center was getting kind of put into play, but it's since gone back down, and our length of stay is one of the lowest ones within our health system, the Northern Light Health System. So we're doing really well with keeping those out, or shorter time here. What we are currently working on and where we're going, we did notice that we'd had an increased rate in our nursing home readmissions. So we arranged a nursing home consortium with several of the administrators and the DONs and some of the staff in the nursing home. We had a luncheon and really just wanted to bring everybody to the table and just have a discussion. What's going on? What can we do? What are you doing? How can we improve our communication? What's happening? So what stemmed from that discussion was that the nursing homes did not have access to our EHR. So we're working with our IT and our security department to provide access for them to be able to get a read only to the EHR so that they can follow up with patients who maybe had pending blood cultures, or there's some outstanding tests that they would like to follow up on, or so that they can look at if there's an addendum to a discharge instruction that came through after the patient was discharged, that they get that information. So that's one of the things that we're working on with the nursing homes. We're also working on a standardized handoff report as well as a warm handoff so that we have RN to RN report happening when we transfer a patient. And we're also working on a smoother transition from the emergency room so that when a patient comes in from a nursing home to the ER, that the transition back to the nursing home is a little smoother and a little more communicative, because that's been a little challenging in the past. So these were some of the things that we identified from that meeting, and it was a really productive. None of this is what you guys are doing. It was no finger pointing. It was all, what can we do? How can we make it better? And it was very productive meeting. We also realized that we had a recent update in our EHR, and when we did that, we had an education glitch, so that the patient information was supposed to be going to the patient wasn't. It was going to the primary care. So when the patients had dressing instructions or specific medications like prednisone taper instruction, that was going to the primary care and not to the patient. So in reviewing discharge instructions, we realized this and have since re-educated and brought in our IT people, and have fortunately very, very easily, by just having the IT people come and re-educate and look at some of the workflow, we've now fixed that. So that piece was a pretty easy fix, but it just needed a set of eyes to realize it was happening. For certain diagnoses, we have recently implemented a standardized system-wide evidence-based practice, and that does include heart failure. So that's coming kind of down from above, but several of the member organizations have representatives within those committees to get that up and rolling. It's currently in a pilot program, but it will be standardized so that we will have the most recent evidence-based care in the order sets, so that when practitioners are admitting, say, a heart failure patient, all they have to do is pull the order set up. It prompts you to, based on creatinine, based on the presentation, based on their prior meds, it prompts you to just kind of do a click off of, these are all the things that you need to do. So, and we also have similar discharge instructions for that. Our providers are all being trained in palliative care so that they can have those difficult conversations. And we have a palliative care team from Northern Light Health who is traveling around to the different member organizations and really working with our primary care, our physicians, both primary care and in-house, to really help them kind of address that and be more comfortable with it. And we also are more and more seeing our hospitalists within house providing a warm handoff to our primary care. So there's actually conversation going on about what happened in the hospital and what needs to happen when the patient gets out. So there's a lot more communication than there used to be. It wasn't just a 5 or 6 page discharge summary that the primary care would have to slog through in the 15 minutes they had the patient in their office. So we actually have really been encouraging that with our hospitalists, and they've actually been very receptive to it and been very good about calling primary cares. So that's kind of it. In closing, I'm happy to answer questions. I just want to say that I guess I'm really fortunate because I've got such an incredible team of people who are really dedicated to what they're doing here, and really empowering our patients and their families, and really just providing the best care that we can in the hospital and out, and really reaching out to patients and families and making sure that they know that we're here if they need them, and ultimately having a better outcome for our patients, our staff, and keeping the lights on, so also in our pockets. So I guess I'm ready for questions.
Great. Thank you so much, Lisa. We'll go ahead and, if you have questions, please go ahead and just type them into the chat. I'm going to start reading off some questions to Lisa. So if you could just hold calling in just for a second while I just get to a couple of the questions that we've already had. The first one was, who absorbs the cost for the nurse practitioner to go out?
So the nurse practitioner actually bills for a transitional care visit. So she bills herself. So it's through her practice, and it doesn't cost us anything.
Great, okay. The next question, do you use a readmission interview tool or a questionnaire?
When I first started looking at readmissions, I did. And I guess I should say, I guess it's pretty much in my head. So when I interview patients, I did start out with a questionnaire. And then I felt like I wasn't forming a rapport with the patient because I was looking down and I was writing things down, and I'm not crazy about going into a patient's room with either a computer or a questionnaire. So yes, I guess in my head I use a questionnaire, but it's because it's memorized at this point. So yes and no.
Okay.
That's not very clear, I'm sorry.
We have another one that says, in readmission interviews, what have you learned? What have you learned in that process? Any takeaways from the interviews?
Well, I'd love to say that there's some kind of pattern that has happened that we could easily fix, but unfortunately, that's not the case. A lot of times, what would I have to say? I would say that it's often something that nobody thought to identify, and so that is really, again, a tough fix. So transportation, I guess, is probably one of the biggest issues. So patients getting to their primary care has always, fortunately, we're in Portland, Maine, so we're in a city, but once you're like 12 miles out of the city, not even that far, you're in rural Maine, and transportation can really be challenging. So that's always been a big barrier, trying to figure out how we can get these folks to their pharmacies, to their primary cares, to their specialists. So we do have some public transportation. We've hooked up with a couple of different for-profits that are fairly reasonable, HIIN, and I can't remember another one, but we also have our transportation for folks who have main care as well. They can have local transportation, and it's covered by the main care. So transportation is a biggie if we haven't managed to address that. And when I interview people or when I do heart failure education, one of the questions that I always ask is, do you have reliable transportation? And if the answer is no, then that's one of the first things I work on, is trying to establish that and how we can make sure that the patient can get to where they need to get to. And for heart failure patients, those folks, it's almost always a dietary indiscretion. So we do really focus on that a lot, talk about opportunities for improvement in diet, and where you can, if eating your wife's banana bread is one of the things that you are not willing to give up, then where are you willing to give something up and some compromise? And so for the heart failure folks, that's usually it. With the COPD folks, it's almost always smoking. They are continuing to smoke. And so really working with our respiratory therapists for that. Those are probably the two things. So salt and smoking, I guess, would be the two biggest things that I could identify that cause some of these readmissions.
Okay. Katie is asking, who is screening and identifying the patients, and are they referred?
Screening and identifying for the transition, I don't understand. For the transition.
Katie, if you want to unmute yourself and you could add a little bit more to that. If you're on the phone, it's *6. I think I actually might be able to unmute you, actually. Katie, can you hear me?
Yeah, we can. Can you hear us?
Yes, yes, we can. Go ahead.
Our case managers are wondering how a patient is identified in the hospital and then referred to the program. How do you identify who screens for that? Is the nurses, the doctors? Is every single
for what
patient
program? For the nurse practitioner, for the transitions home, or?
Really, for any of your programs, how are you identifying the patients, I guess is what we're asking. Like, is it done, is someone looking at every patient? Or?
Well, every readmission comes through me. So anybody who's readmitted through within 30 days comes back to me anyway. So for readmissions, that happens. But as far as heart failure folks also come to me. I do all the education for them. So I go through every single admission. We're a small hospital, so that's possible. So I go through for all the heart failure, the COPD, the AMIs, and the pneumonia people, and I will see their admission note and go see them.
Wow.
Is the high-risk stratification tool embedded in your EHR, or
yes, yes, it is.
Yeah. Okay, great. Thank you.
Yep.
Does anybody else want to unmute themselves and ask a question? And I'm going to go ahead and ask a quick question. Lisa, about the health information exchange, does your hospital participate in, I'm assuming that Maine has their own hospital information exchange that's available to all the hospitals and physician offices, and maybe even the nursing homes as well. Is that something that you guys utilize or participate in?
I think you're talking about Health Info Net, which is Maine's kind of catch-all for all the hospitals in Maine that discharges and testing and ER visits and admissions all funnel into.
Okay.
Yeah, we have, it's called Health Info Net.
Now, when you were talking about connecting your EHR with, say, the nursing group homes or whatnot, is that InfoNet, is that something that you guys have thought about or use bounce back and forth between the two?
Well, they use Health InfoNet, but Health InfoNet's kind of spotty. It's sort of like reception in the mountains. Sometimes you get it and sometimes you don't.
Gotcha.
So we, with the nursing homes, we're actually going to give them read-only access. And they've selected a couple people within their nursing homes that will have access to our EHR.
Okay, gotcha. We have a question from Lena. Is medication rec of any concern with readmissions?
I'm sorry, I didn't hear that.
Is medication rec of any concern with readmissions?
Oh my God, yes, it's huge. It's huge. Med rec is like the biggest nightmare ever to everybody. And so the patient has a med rec when they first come in by the nurse that sees them. The physician in the ER does a med rec, and then the pharmacist who comes in and talks to the patient and also does a med rec by talking to the patient and calling the pharmacy that the patient usually uses. The patient has another med rec before they're discharged. They have med rec if they go to a facility, and then the nurse practitioner, the transitions home nurse practitioner, will also do a med rec, and I do a med rec with the patient when I call them. And we still have errors, so So yes, it's a huge concern. And I don't know how to fix it, except that, you know, you try, and you go through, and patients come in with lists that aren't updated. They tell you 3 of the 5 that they're on, and the last 2 are the pretty pink pill, and, you know, that little blue one. And it's just, yeah, it's huge for everybody. It's almost unreachable. I can't even begin to describe. So yes, it's a huge factor.
All right. From Beth, are your providers consistently using evidence-based order sets and involved in the updates you mentioned? Hospitalist, primary care, cardiology?
Yes. So they, like I said, it's a pilot. So there's just a couple of different order sets that we've worked on thus far. And right now the pilot is for heart failure. And so cardiology is involved. We've got some primary care physicians that are involved. We've got nursing from units, as well as offices, as well as home care involved. So it's a nice mix of everybody with some feedback. So yeah, we are. And the plan is, once the heart failure is no longer a pilot and it's in use, then they're planning on moving on to one of the other diagnoses that sort of is everywhere, like COPD, for example. I believe that's the next one on the docket to really nail down, using pulmonologists and, again, all of that staff.
Okay. I have a quick question about the patient care navigators. I'm just kind of curious to what kind of caseload they have. Is it, let's say, 20 patients per one navigator, or a little bit higher than that, lower?
Well, bear in mind, we're a pretty small hospital, so it's manageable with one person, and I've done it for years. In any given week, I could be following 10 or 12 patients, doing the education on the floor. I mean, I might have 5 or 6 patients on one day and then have none for a couple of days.
Okay.
So it varies, but I'd say probably on average, it's probably 10 to 12 patients a week that I'm following. I usually follow them for about a month, long enough to keep them out of here.
If anybody else would like to just chime in, just go ahead and unmute yourself.
I did notice that Erica Sieber, who's one of our nurses on our cardiac unit, had written in that we do multidisciplinary rounds as well. So every patient is rounded on a daily basis.
Okay.
And that multidisciplinary round includes UR, reviewer, a physician, the PTOT, our dietary, and I'm trying to think who else is in there. Social work is in there. So
we've got our occupational and physical therapy utilized in transitions home, from Jessica.
So that's a good question. So if the patient wasn't hooked up with nursing, with home care services, and everybody gets evaluated here pretty much in the hospital, and they may not get an official order to be evaluated by OTPT, but probably 80% of our patients have OTPT orders. And if they don't have a need for services while they're here, when the nurse practitioner goes in, she'll do a home safety eval, and she can make that recommendation to the primary care. So if she feels like she's in there, she's working with the patient, she's seeing something that maybe the patient wasn't referred for some reason, then she can make that recommendation as well.
Okay. What if they do not qualify for home care therapy?
So if they don't qualify for home care therapy, then we can certainly make referrals to outpatient therapy. And that would be in a note to the primary care. It might even be in a discussion when the hospitalists call the primary cares and talk to them. So.
Okay.
And that whole homebound thing is a little bit crippling at times, and what we would like to see have happen from the point of discharge, but, you know.
I believe when Mike Silver and myself were out there and we conducted the first interview for this project, I believe it was Mercy that was talking about how you engage kind of community leaders and first responders as well, and possibly hosted like monthly meetings to talk about high-risk readmission patients. Was that correct? Did I remember that correctly, or does that sound right?
I think you did. It's not something that I'm involved in. I do believe that our mission, by our VP of mission, I know that she's very, very active with our first responders. Okay. And with our MedQ and our EMS group. So she does meet with them. What the regularity I can't speak to, but I know that she does meet with them pretty regularly. Okay. And again, we also have, we've got a social worker in our emergency room as well, who is very connected to a lot of our community services like our Opportunity Alliance and Amistad and the shelters and our healthcare, our health center. So she's very connected as well, so that we are able to actually help with a lot of the emergency room recidivism and connect those folks too. So okay. Yeah.
I think this next question kind of rolls into that, is what happens with patients with no resources or are homeless? Is it the social worker there in the ER that's kind of getting everything started from that patient right away?
Yes, yeah, they'll definitely meet with those folks, and then they obviously will score quite high on the screening, and then we'll have, and care management then will get involved. And depending on how much involvement we need, we may end up getting our VP of mission involved, our patient advocate. We've got a patient advocate who works quite a lot with patients as well. So depending on what the needs are, yes, we've fortunately got resources within the hospital as well as outside the hospital.
Okay. So I want to take it back kind of to day one, when you first, the early 2010s, when you guys were receiving these penalties for the readmissions. Was this something that the C-suite came to the staff, or was it the staff that came to the C-suite and said, we identified this problem, we know we're getting penalized, we want to revamp our whole program? Was it, one side or the other side, or was it a collaboration of both? Can you just kind of talk about maybe C-suite buy-in to this whole program as well?
Okay, what's C-suite?
Okay, so like your CEOs, your chief financial.
Oh, okay, all right, yeah. Okay. Our administration, I got you.
Yeah, the administration. Okay. West Coast
okay.
calls it something different, I guess.
So that's okay. So I kind of came into the tail end of it. We already had the grant, and we were looking for, so our cardiology department actually were the ones who obtained the grant. And the director, or she was the manager of cardiology at the time, was looking for somebody to kind of get the ball rolling on. And I don't know if it was the grant that kind of spawned the whole let's look at our numbers, or if it was, oh my God, let's look at our numbers, we need to get a grant, or how can we fix this? So I don't know what the order of things actually were when they happened. I just know that when I took the job, it was, we got this grant, this is the goal, how can you do this, what do you need for support? I was very fortunate. I had an amazing manager who just really respected autonomy and said, I just want to see results, so let me know how I can help you, otherwise this is in your hands. And she just kind of let me run with it, and I was, it just, the pieces all fell into place, but I don't know as far as what order that all happened in.
Okay.
So I could refer you to the person who this all started with, but I don't know what order it happened in.
That's okay. And then as far as physician buy-in, was that, kind of like moving mountains to set up some of this stuff, or were they on board from the beginning as well and kind of help lead?
No, our physicians, as long as it doesn't add a lot of work to them, they're almost always cooperative and willing to do whatever needs to happen. So when we first started talking about heart failure and making sure that we're practicing evidence-based, and we had a a cardiologist champion from within our cardiology practice who met with us, met with the practitioners, just really had so much enthusiasm. I don't think that anybody could have said no to him. And so they were all really pretty receptive to it. And the fact that he was more than willing to say, if you got a problem, come to me and I will do what I need to do. And so I think that really set the precedent for how important this was to our hospitalists and our physician's assistants. And so everybody was very cooperative. When you see that coming from above, it has quite an impact, and it did.
Great. Does anybody else want to unmute themselves, ask any more questions? We have a little bit of time left. If not, if you want to chat it in.
Hi, this is Robin at Mercy. Can you hear me okay?
Yes.
Oh, it's not.
Hi. So I just wanted to comment. We did form our own physician group. Our cardiology practice came in to us in 2011. So it was during that time we were really standing up an outpatient physician practice and seeing patients on an outpatient basis that we really started to look at quality from an outpatient and also the whole continuum of care. And that's where we started to develop how could we move the needle even further. And now that we had cardiology present and working with us, what else could we do to impact change with this subset of patients? So that's how it all came about. And then we started looking at grants. So just to give you that background.
Thank you.
You're welcome.
Thanks.
Anyone else want to chime in? *6 to unmute if you're on the phone, or you just click the little microphone button. All right. Not really hearing anything. I'll go ahead and give everybody back a little bit of their time. Lisa, I just want to say thank you very much. We really appreciate you sharing your story. And we appreciated you guys letting us in the first time just to kind of learn from you. And thank you for taking the time out of your day to share, the best practice that is Mercy. So I appreciate it.
Well, thanks for inviting me, and thanks everybody for listening. I'm really very happy to, and you feel free to give out my email. I'm nothing that we're doing is original. What we're doing is what we have the resources to work with, and I have a lot of support with my team members, so I'm very fortunate in that. So I'm very, very happy to share any information that I have if anybody has any questions or wants any more information from me.
Great. So what we'll do is we've recorded this session, and what we'll do is everybody who's registered, we will go ahead and send a follow-up email once that recording's been edited and cleaned up. And if it's okay with you, Lisa, I'll attach your email your email address to that correspondence. And then if anybody has any questions or follow-up. So I really appreciate your time, and I hope everybody has a nice day. Thank you.
Thank you.